Skip is the Director of Spiritual Health at the University of New Mexico Hospital, as well as the Director of Spiritual Care and Education Program. He received his training and education in psychosocial sciences, intercultural spiritual health, and clinical pastoral education. He is endorsed by the American Humanist Association and credentialed by the Association of Professional Chaplains and the Spiritual Care Association. Skip's advocacy for spiritual health and intercultural support is grounded in diversity, equity, and inclusion, and emphasizes the worth, dignity, and agency in one's search for meaning and capacity to shape their own lives. He seeks to support patients and families to embrace that which affirms their intercultural and spiritual well-being in their journey of life and death. Under his leadership, the Spiritual Health Department has evolved to be more inclusive, culturally responsive, and more broadly focused. I look forward to his presentation today that will bring all of us up to date on the resources available to our patients and their family. Skip, you're on.
Thank you, Dr. Waldorf, or Ann. Ann is my longtime friend, as she mentioned. And in addition to our friendship, she's been a peer and a mentor for me in my professional development. And I appreciate her work professionally significantly. So thanks, Ann, and for the opportunity to be here today. So it's Friday afternoon. I'm aware of that. I know this is a grand round, and I'm thankful to be here, and I'll do my best to keep us engaged in some sense. And my intent and hope is to give an overview of our discipline of spiritual health that is primarily to UNMH, but expands to all HSC. Our discipline is unique in that when you hear spiritual care, spiritual health, or pastoral care, it's sometimes a gray area of just what do we do? What do we provide? And so often to get our head around just exactly what our discipline does and how do we define spirituality, ultimately it comes down to succinctly two words. We work with meaningful connections. And so that meaningful connection of a patient or family member or staff member, or any of us, might be an existential connection, or it might be nature, it might be family, it might be one's own personal development. And so we work primarily with patients that are in life-changing situations. And often they present with acute challenges. And due to the size of our staff, we often just get one shot. Sometimes there's some follow-up work, but it's so we're entering into a crisis situation quite often and looking to help people through those life-changing situations. I've worked at UNMH for 11 years. Most of those years has been as a chaplain, and at the beginning of the pandemic in 2020, I became the director of our department, and we begin to move to a much more inclusive approach in our provision of support. And just have a couple of slides that gives an overview of what we focused on. We've moved and are hoping to move and moving to a qualitative approach. And we frame that by our approach is intercultural care. Common term would be trauma-informed care, and that's our hope. And we're continuing to expand our approach in a number of those things. We have required all of our chaplains to be board certified, and that board certification is based on a Master of Divinity, which is a 3-year program, a 12-month residency program in a healthcare setting, which is about 20 hours of patient care and 20 hours of deconstruction with psychosocial leaders to help us to really not bring our own stuff to the table. And then another additional years, much like social work, of 2,000 to 3,000 hours post-residency. Chaplains sit before a board, and that board is a 35-page document for philosophy, and then standing before a board review to answer any questions that might take place. So there's a significant amount of training that takes place in our discipline. So we moved to a requirement that as a minimum standard, our chaplains have that background to be part of our team. And all of those are based on national standards. Our scope of practice, we moved to a unified scope of practice, and that's the third bullet point from the bottom. It focuses on, as I mentioned, trauma-informed support. And when we meet a patient, we begin by attempting to provide whole person care, and often our patients come from a marginalized situation, and if they share their intersectionality, we affirm that and begin to work through their lens, and it's really care with the patient rather than for the patient, being patient-driven care. Our 6 major domains that we work with is trauma, their losses, how do they cope, and whether it's life-giving coping or life-limiting, and then begin to explore their needs, their hopes, and then what resources do they have, whether they're internal resources or external resources, and then to connect them to either internal or external resources of support. And so those 6 domains capture our scope of practice with working with trauma, loss, coping, needs, hopes, and resources. Down on the bottom are some of the credentialing agencies that we work with. A significant, these are books that we've gone through in our training. They're current evidence-based practices, leaders in our field nationally, internationally. And we've used these books as we've gone through our significant training. And I would say the most important book that we've gone through is the second to the right, is The Post-Colonial Image of Spiritual Care. And historically, spiritual care was grounded in Christocentric approaches, often called pastoral care. And while it may be helpful for some, it often is something that introduces moral or spiritual distress by forcing someone's belief on them, or a chaplain's belief, believe it or not. And so much of our work was to broaden our approach and to identify that much of our images of care need to be much broader than a Christocentric lens only. And so that's been a very important book, and it would be worth building if you're looking for something to read in your time off. That would be a fun one. So that's been excellent. A excellent program out of Atlanta in the Emory Health System. They're doing a great job in their spiritual health department, and they've been significant leaders. Many of the authors come through that system. I just wanted to mention one thing. we have been working on the elimination of the introduction of moral or spiritual distress. And it's sad to say, but historically, our approach in the hospital and has, rather than supported patients, at times we have actually introduced moral or spiritual distress. It's difficult to own that, and it's something that we changed in our department. And I'll give you an example of how that might manifest. We've had volunteers that have come in the hospital and gone door to door to our patients and begin to present their own faith approach, and then with an intent of good, but actually introducing harm. Or we've had uncredentialed chaplains coming in that did not have the training that I mentioned, and though not intentionally, has in those traumatic situations bled through their own beliefs and worldview and begin to introduce some spiritual distress or moral distress for our patients. So we've addressed that, changed our philosophy. We have an excellent team, and I'm very thankful for that. Much of these other things has to do with our structure. I know how many of you must love remuneration with RVUs, and I don't know if your discipline does that. We brought that into our team to measure our work, and while we're not remunerated for it, it's helped us to measure the work we're doing in a number of helpful ways, and to increase our staff. So just this is 4 major sections of the 31 competencies, which we're grounded in, and they're in. And then significantly, there's 6 of those competencies that we've been focusing on as a team. And number 1 is that we're respecting the physical, emotional, cultural, and spiritual boundaries of others. And that is an important competencies that we frame. And then the 4th one down, to provide spiritual care that respects the diversity and differences, including but not limited to culture, gender, sexual orientation, spiritual and religious practices. And so, again, very thankful for our team. We are intending to provide whole person care, trauma-informed care, intercultural care, and help patients and or families as they're traversing their situations. We also have a code of ethics that we are held to, and again, the highlighted sections are zeroing in on those same things, and then we have a structural process we go through. As a discipline, we need about 13 chaplains to provide qualitative care to our 600-bed hospital, and we're sitting at about half of that. And so one way we've addressed this is we do have a team approach. We have to triage the most acute situations, and we break our chaplains down where they're covering anywhere from 5 to 7 units individually, and we rotate that around. But we have a team approach. We do have a 24/7 chaplain that's on duty that manages care, much like a charge nurse on a floor would do that. And we've moved away from having chaplains assigned to oncology or women's service line, and all of our chaplains provide care to all of the units. We did go to a team approach. I mentioned, here's just the domains that we work on. I mentioned that already about working with meaningful connection, their intersectionality, and then those 6 domains. If you are looking in the chart and see a note from a chaplain. I thought it would be helpful to see our standardized note that would come forth in Cerner to give some kind of help and meaning. And this is hopefully for all disciplines. And really the onus is on the bottom where it says pastoral care summary. We've gone away from the term pastoral care, but it's still embedded within our system. And so we prefer spiritual care or spiritual health. Yet the domains, if you'll see meaningful connection, just a basic note, their trauma or loss, their coping, their hopes and needs, their intersectionality that they might share. It's important that we're not projecting, but what a patient might share. And then any interventions that we have accomplished. And so as you look at a note, that often has been helpful to understand what the patient might be going through to the various disciplines. So in our work, I'm aware that the audience that I'm speaking to, we do not have the level of training that I'm projecting or assuming that many of you have, yet we are entering into these acute situations with patients. And so this may be elementary for your team or not. It is what we think about first and operate with as a discipline. So we're coming into an initial care encounter and looking to come in from a place of safety and trust. We can go no further with them unless safety and trust has been established. And within that, because of the ongoing trauma support that our chaplains steadily give, it's important that we are strong in our own self-differentiation, that we're not bleeding through our own stuff as we're working with the patients. And a significant challenge and something that we need to be aware of is being too connected or disconnected. And I know there's a number of names for that. We could be fusing with the patient, or we could be withdrawing. And we continually, without judgment, look to strike that middle balance. And the biggest thing that as our chaplain team regularly works on, and we do share with one another, is to be able to recognize when we become too close, when we begin to withdraw, and to be able to recognize and adjust accordingly. I'm just hitting some highlights through these slides. I want to leave some time for some questions. And I've shared the slides with Robin, and you're more than welcome to have those in the future. And so something that we are aware of and continually to speak about is that we do not want to consider ourselves inclusive. That term inclusive is actually about the chaplain and not the care seeker. And ultimately, inclusiveness looks for commonalities and some kind of shared belief. And in doing that, it minimizes the other. It minimizes the vast differences that others may be going through. And so, again, it's real important that it's patient-driven care, that we understand who the patient is and look for their meaningful connection and a worldview by which they understand. And then it's all about the patient and family. And then within, while we do call it spiritual self-differentiation, within our work, we are continually aware of power. And in that power, that we are looking to have power with the patient, and not to use power over or power under. But we work hard and identify those power dynamics with our patient support, and look to support them in that. So I mentioned intersectionality, and as we have a broad array of patients that are coming from all over the world and with significant ways that they identify themselves and by which they've been part of a system. And if we're going to enter into supporting individuals in a short-term, perhaps 1-hour encounter, helping them to make sense, it's important that we understand as they share the privileges or oppressions that have informed them throughout their life. And this is just some of the identifiers of the various intersections by which we're all part of. I am a white male, 12th generation from New England, and I come with significant privilege and power. And it's important that I not only understand my own privileges, but as I work with others, how my embodied privileges may stand in the way of that care encounter that I'm looking to walk with someone else, and to be able to identify that. And then as a care seeker begins to share a number of the challenges that they have. I would say that intersectionality informs our work significantly at the outset as we look to walk alongside patients in our work. And then we are working with their narrative themes as we're listening for their trauma and loss and coping. Often the frontline emotion that comes forth is anger, and as you know, there are embedded themes and emotions underneath that, and we're there to support the patients as they process their losses, perhaps their trauma, the violence that they've faced either past or presently, and assist them in their coping. And so we do often encounter individuals that have been subjects of violence and trauma, and these are just cues and markers for their physical and emotional and cognitive symptoms that might arise, and that violence might be physical and psycho or social and spiritual or sexual ways that have happened in their life, and we enter into those very situations quite often. And again, as these is just breaking down some of the specifics there that we're working with, and we are looking again to assist them and to identify areas that might be life limiting in their coping and or life giving as they make sense of what they're going through. And so we have training on the cycle of violence that takes place. We're so often just getting a snapshot, but often they're presenting in a traumatic state that's taking place. In our trauma hospital, we run the gamut of situations and backstories that have taken place in our support. And so we again are working with our own assessments in those things. I'm not going to take time to break down all of these things, but while we are chaplains, much of our work is right up front initial trauma that's taken place that's brought them through these situations. Our chaplains average about 12 acute potential end-of-life situations each per week, and it's ongoing in our work. It's significant. My major work as a leader is to support the chaplains in their work and the tertiary effects that has. I've often wondered what's the job retention, or what's the length that a chaplain or an individual in our work, that many of you are involved in, can continue in. And that strong sense of self is the importance in that. In our work, we're often listening for themes of loss, and so that individuals are able to begin to process the grief that's associated with those losses. And much of our work is to assist individuals later in their life as they begin to process those losses in an ongoing way. But our work is acute, and we've located ourselves in that short-term support. Often we identify in our listening for losses and grief, whether it's delayed grief. Interestingly, when we're working with a loss of a patient, maybe it's the matriarch, the mother of the family, that's older and near a full life. And what will happen is an adult child will begin to share the losses that they've had in their life. Perhaps it's their own child earlier, and it will be a 3-year-old loss that will present itself about someone else they've lost in their life, rather than the immediate person right there that they're going through. So it's compounded grief, and it comes in numerous ways. And we have to be grounded to be able to work through some of those things. I am aware that to get true and significant help, there is significant therapy that could be helped in situations. Our work is that immediate acute trauma that presents itself. And then we are identifying how individuals work and with their losses and their coping. We do not look to change their situations. Whether we might assess that it's life limiting, we're there to help them to process through what might be helpful for them, what's helped them in the past, and what's potentially not helpful. And so we're right up close in helping them begin to cope. We are on the front leading edge quite often of suicidal ideation that presents. We are not trained to work through all of those things. We cannot get a psychological assessment. We do not have that skill set. It's outside of our scope. We do need to be able to recognize the markers, and then begin to work with the other team members to make a referral for a psych eval and to begin to address some of those things. We do need some basic tools to begin to work with individuals in that setting. So we have significant training on suicidal ideation assessment on the front end as that presents. This is some of our language that we use for our charting and in the spiritual needs. And while it may be their worldview and their existential beliefs, it also moves into other feelings and what they might be going through. So we do have an assessment of spiritual needs, their relational needs, and we're looking for their support system. Some of their emotional needs, we're assessing those things. Sometimes bottom left, those little icons with nonverbal patients, they are able to potentially be aware we're just giving them a picture and having them point to what they're going through. And then we are working with their hopes. That particular domain might be their intermediate hopes and then their ultimate hopes. And so quite often they're looking for a favorable test results. They're looking to be healed, to be fixed. And then it does move on to their ultimate hope that moves beyond the set of their present circumstances. And then within their resources, we're looking within them, just what is internally, what's the tools that the patient might have, what's their relational support system, and then what is beyond them that's super personal, that what language they use, what lens do they use to make sense of those things. So I'm near the end, just to give you a heads up, but I wanted to just hit some pointers. So I mentioned that we've changed our philosophy, and we've stopped any outside community, anybody that's not trained as a chaplain with a level of training to be the first person in the door within our scope of practice. And so our chaplains come in and do that assessment. We do our work, we give the support, and sometimes there's external support that would be helpful. And so we do believe there's value in community connection, whatever that might look like. And so we do assist with rituals and community connection by connecting those patients or family members to their outside resources. And so we're involved in that in a significant way. And yet we have moved all of those, what we identify as resource, to the back end of care as a way to support them after we've given them some support. And so that's a significant change in our approach. And while the intent of others may be helpful, the impact often has not been. And so we moved them to a resource. Some of our work, employee well-being is on the rise. And before employee well-being was an established discipline, our chaplain team was responsible for the emotional well-being of all the staff within UNMH. Now we're working side by side with employee well-being, and we're more patient-facing, yet a significant amount of our work still remains with the supporting staff. And so we do offer one-to-one support sessions. Often units go through challenging situations. We are on point for the initial debriefings that take place, and then we hand off to some of the outside resources, particularly employee well-being. But we are there to support teams or individuals in our work. And these are some of the disciplines we work with. I believe Outcomes has a new name now. This is still I'm still holding on to that, but employee well-being and our team works quite a bit together. Some of you might be involved as a peer support person with your colleagues and peers. And so that is another significant resource we use. Then we do refer to Outcomes, and there's a first responder line as we're going through those things. And so that is a very quick fire hose overview of what we do as a discipline. And I wanted to bring us to this point and open it up for any questions that you might have. I can say this while you're thinking about that. Thanks, Ann, is that we are on Tiger Connect, and underneath roles, if you type in chaplain, spiritual care chaplain, we have 24/7 connectivity that way. And then I'm personally on Tiger Connect. That's the best way to reach us 24/7.
Well, Skip, thank you so much. Really appreciate your willingness to come and sort of bring us up to speed. I know the inpatient units have definitely worked in a collaborative way with you, both within the mental health center and also the main hospital. I would encourage any of you who have questions to just unmute, or feel free to put them in the chat, and I will watch that as well.
Thanks so much for your discussion. Avi Kreichman, I'm a child and adolescent psychiatrist. I was wondering how you and your group would respond when a spiritual crisis is actually the presenting problem. There's a lot of people who have terminal illness or suffer severe trauma who feel that they're devout and that they've led a good and spiritual and religious life, and then have a question of, why do bad things happen to good people?
Oh, thank you, Avi. That's a very common question that presents itself. And I can tell you what we don't do. We don't answer that question directly. And so we come alongside the individual and often ask them what they think and what their, and when they say what they think, what is their worldview. And all of our chaplains are well trained in a significant amount of various worldviews, whether they're spiritual or religious system or others, so that we're generally aware of what might be life limiting and life giving. And so we work with mystery and use of language that might help them to begin to process this. It depends on the situation. We might leave them with no answers and there to support them in that. And there are a significant amount of religions and worldviews that do have easy, or when I say easy, approachable, life-giving answers to that. There's some worldviews that are generally life-limiting and can be shame or fear-based. And when we're in those places, we don't seek to change what their family systems view are, but we work within the context of that. It's a very gray answer, but we're there with them and look to support them with their own views.
So this is Kathy Holland, and the question I have is, are you helping patients with dealing with the Elizabeth Whitfield End of Life Options Act? And how often does that come up? And just curious about your experience in that regard.
So I'm not as well heeled in my education as I need a little more information. Are you speaking of medical aid in dying?
Yes.
Yes. Okay. So we are personally, so it moves into personal and professional, but personally, our chaplain team are advocates of medical aid in dying and see that as a viable option. So we support the individuals in that. I'm on the ethics committee, and that's something that we process through there. There is a leadership team in our state that I've been on the fringe with. And so It's in our work, it is often a 1 or 2 off time. And so our work would be initially supporting the patients and then connecting them to someone that's boots on the ground that can help them go through those steps.
Great. Just one other question. How often does that come up in your direct work?
So the discussion comes up that I'm aware of once a month. So minimally.
Okay.
Within the hospital setting, when we were involved with providing support at the clinic and the cancer center, we're not there right now. And where that was more of an ongoing support, where there would be potentially 10 to 20 sessions with individuals over a 6-month or less process, it came up quite often. So, and that's my own lens that's informing that, rather than as a director or as a chaplain. And so that would be weekly, perhaps, or 4 or 5 times that amount. So I would say within that prognosis and challenge and end of life within oncology or similar more long-term situations. And we do work with the palliative care quite a bit. And that is something within palliative care that presents itself quite often.
Great. Thank you very much. That's very helpful.
Yep.
Kathy, I just wanted to mention that there is a medical aid in dying webinar series. And just at this noon, I co-presented with Rachel Rankin in hospice to talk about the interface between MAID and depression and suicide. There's a whole series of that. And Skip, just to let you know that there was a lot of mention of you and your colleagues' work throughout the series.
Excellent. Thanks, Avi.
So I'm trusting it was not all negative, though
it was very positive. And I think the one thing too is that you alluded to that's I think very important, Skip, is that your approach and your staff's approach is very much community and family as opposed to just solely individual. And that is very much in alignment with the MAID clinicians.
Nice. I would have loved to have been at that at the table listening to that series. So
any other questions or comments? All right. Skip, just to know, Dr. Delmore puts in the chat that it was an incredibly useful and inspiring talk, and to thank you and your colleagues for the work that you do. So, well, if there are no more questions, we'll let you guys go. Skip, thanks again so much for being willing to be here and really aligning a lot of the work that the spiritual health department is doing with regard to what we're trying to do, I think, here in behavioral health as well. So nice alignment.
Thank you very much, Anna. Really appreciate it. Appreciate the opportunity, and we're all in this together.
Indeed. All right, everyone. Robin has put the link to the sign in the chat, and then we'll be putting up the QR code as well. So thanks to everyone for their attendance, and have a good rest of your day and a nice weekend.